Okay, so our second presenter is Professor José Brunner. José is the director of the Cohn Institute for the History and Philosophy of the Sciences and Ideas at Tel Aviv University, a senior fellow at the Edmond J. Safra Center excuse me, for Ethics, and faculty member at the Buchmann Faculty of Law at Tel Aviv University. Brunner's areas of research are diverse. They include the relationship between law, memory, and identity, the history and politics of psychoanalysis, the politics of the mental health discourse on trauma, psychological theories of Nazism, modern and contemporary political thought, and the history of personal compensation for Holocaust survivors in Germany and in Israel. José, please.
Okay, thank you very much. Thank you for the invitation to speak here, which for me is a continuation actually of the year here as a fellow at the Safra Center, so I'm very happy to do this. Speaking after Elite and Liora has its advantages and disadvantages. Its disadvantage is that after hearing something so poetic and philosophical, I have to bring you down to the sober and, well, prosaic professional language of psychiatry, so it's not going to have the resonance of what we just heard. The advantage is that, of course, from my point of view, and that was just the end of the discussion now between Chaim and Liora, Elite and then Liora in her wake described a post-traumatic stress disorder. I mean, from the point of view of psychiatry, Améry would clearly be somebody suffering from a chronic post-traumatic disorder. So that brings me to the central question of my presentation here, which turns around one central question. Which is that post-traumatic suffering, in the point of view of psychiatry, is the effect of a traumatic event. What turns it into traumatic is that it's excessive in some way. It is too much of something, too much violence, too sudden, too abnormal, too violating the general rules of human relations, and so on and so forth. This event causes an excess in the mind. So it's an excess that happens outside that turns into an excess inside. Too much stress, too much fright, which overwhelms the mind. And this excess of fright causes, again, in psychiatric terminology, an acute reaction, an acute post-traumatic reaction, or an acute traumatic disorder, an acute traumatic reaction, various terms. They all have to do with some loss of control of what you talked about earlier, of agency. In some way, agency gets lost in the sense that the control over temporality, and I think we just heard a lot of this now from Elite and Liora. Somebody starts to live in a different temporality. Relations to people around him or her are no longer the same. Feeling of alienation. Feeling of to reenact or to re-experience what actually belongs to the past. There is a model that then explains how an immediate reaction of this, an acute reaction, which is not problematic for anybody in the psychiatric field, how an acute reaction can turn into a prolonged reaction. And this dose response model, this model says the higher the dose of the trauma, the stronger and the longer the response. So this is why it's called dose response model. It's not my term. So the stronger the dose of what you experience, so the stronger is the response to it. And this explains why some people recover from their trauma after 1 month, 2 months, 3 months, 6 months. 6 months is the time when, according to psychiatrists, this turns into a chronic disorder. So this is a monocausal explanation. Something happened, torture, in the case of Améry, and if it goes on suffering from it and not getting over it and re-experiencing it, we explain it by this original event and by the fright, by the loss of trust, and so on that happened at the time. In this model, the chronic post-traumatic suffering is the continuation of an acute post-traumatic suffering. It simply continues it. So the explanation simply extends one to the other. And these are the simple principles behind it. It's a single explanation. You explain the chronic disorder analogically to the acute disorder. It focuses on the anxiety, on the stress caused by the traumatic event. It's quantitative. The more excessive, and so on. Excess turns into an outside excess, turns into an internal excess, turns into a loss of control, and so on and so forth. Now, there comes my argument. This is the general commonsensical view of chronic post-traumatic disorders. But I think there's a second etiology that I can trace throughout the history of etiologies of chronic post-traumatic disorders, and I'm focusing now on the chronic post-traumatic disorders only, because anyway, the acute ones are not really a problem for anybody, not for insurance companies, not people recover, so there's not much to pay, they come back to work, they come back to their families, so everybody knows if you go through something horrific, you need some time to recover. This kind of goes along with our general view. The problem is the people who become chronic patients. Why doesn't Améry get over what he experienced? Why does he remain, in Chaim's term, a survivor in the sense that this becomes the center of his identity? So the alternative etiology is not one that is a quantitative one, that is an analogical or extension or monocausal or dose response. It has a different logic to it. And this different logic relies on a supplement, on something that intervenes, that happens, and what intervenes there is an excessively moral or immoral emotion. And I want to go with you shortly through this second etiology that I think is there throughout the history of chronic post-traumatic disorders. Because in that etiology, the chronicity is not determined by the original event, so it's not dose response. Instead, what happens is that an acute disorder develops, and this acute disorder, by unhinging the mind in some way, by creating an internal imbalance, by diminishing agency, allows for these moral or immoral emotions to impinge on the mind in an excessive manner. So in this second model, moral emotions become central, because chronic disorders are no longer simple extensions. There are people, chronic patients are people who have undergone a significant transformation. And temporality comes into it. I'll get into that a bit later. This transformation, which becomes the center of the second etiology, which is not a result of the original event, which is a result of the function of certain other emotions that arise, it explains all the changes the chronic patient goes through. A change of emotional attitude towards others, towards society as a whole, towards the future. And I want to explain now this notion of moral and immoral emotions. I take a very simple explanation that I took from Jonathan Haidt, not a philosopher, really a psychologist. This is the division he suggests, and of course this division is open to a lot of criticism. It serves me for my purpose here. Moral emotions, and you can classify them otherwise, it doesn't matter, I think, to the argument. That moral emotions attribute importance to interests and views of others in relation to the self, so these are emotions like guilt or shame. Immoral emotions attribute predominance to my own interests and views over those of others. I don't really care about others. So you can also speak about self-oriented and other-oriented emotions. You could use other terminologies, and amoral emotions in this division are emotions that where I'm in the center, but not necessarily against others. I can also join forces with others to fight my fear or to overcome fright. I don't say I'm important and others are not, but I also don't say the views of others are important and not mine. So they have no hierarchy between myself and others. According to this etiology, an acute post-traumatic suffering is caused by the original fright, by this excess of fright or fear, while then the second type of emotion set in. So there's a loss of control, but this creates a niche, and now new emotions in their excess create the chronicity and not the original fright. So my argument basically is, if you look at the history of the etiologies of post-traumatic disorders, you can note the general, I think, more commonsensical model that everybody knows more or less, and that we sort of assume, oh yes, the trauma was particularly strong, so it is difficult to recover, to another model which says all the original trauma needs to do is to create an internal imbalance. And then let's see what happens, what other emotions emerge, because they will then define whether this original acute trauma will turn into a chronic one, and it's not the original event that is the definitive one. I'll go very shortly through a few examples to show you what I mean. The history starts in the last third of the 19th century, but it leads up to today, and I think these two etiologies are in a constant dialogue, debate, conflict, contradiction to each other. They sometimes can be found in the same texts. I mean, sometimes you can find physicians or theorists wavering between the two explanations. I think especially if a certain phenomenon is rather new, they try both angles. So here you have John Erick Erickson, probably the most important author, professor in London, of his time, of the last third of the 19th century, writing on the shock that people experience in a railway accident, which at the time was the most awful accident people could think of, because railways had this tremendous speed of 30 kilometers an hour, and people thought this is so frightening that, of course, when an accident happened at that speed, then it leaves a lasting impression in the mind. So the mental shock is a result really of the too much, of an excess, in this case an excess of speed, an excess of fright. But in another part of the book, we can see that what really leads to a long problem of these people to recover is not at all the original fright, but the anxiety is connected with the collapse of business. What happens if, through the acute trauma and through the legal problems I have to get into, I cannot get back to work? So this is a completely different issue. One says the original fright, the speed, is determinative of the chronicity. The other says what happened is that after something happened to me, I now have to cope with a business that is collapsing and with litigation. So these are two different stories, and both can be found in Erickson. William Page, who was a doctor for the Northern Railway, he was actually working for the railway company, so he had a very different view. For him, what happens is that there's a shock. Again, something happens to the mind. But what then happens is that people start to focus on their body. They start to think, what do I feel? What happens now? Do I have pain? Is my body like before? Has there been a change? So it's just nothing to do with the original shock. Now, why are these differences important? They're not only important because we have two etiologies, or here even three etiologies: the fright, the worry about the future, and the focus just on myself, and I ignore everything else. And you can see the difference. With Erickson, it's the businessman who has to keep his family. With Page, it's the person who is no longer concerned about anything else other than his body and what he feels. So it is very selfish. The difference, of course, is not only one in theory or explanation, but also one in therapy. Erickson advocated rather simple procedures, legal procedures, to allow people to get compensation for what they have suffered, because this will allow them to get on with their life and so not prolong their trauma, while Page advocated to give them no compensation at all, out of a therapeutic point of view. Again, remember, he was working for the railway companies. But it was, of course, only to help the patients, not to give them any compensation at all, because if you don't give them compensation, they have to go back to work. If they go back to work, they can't focus on what they feel all day long. They are busy with other things, and this will be the most helpful therapy we can give them. Okay, so you can see here Page saying that this is a vicious habit that develops out of the abandonment of the conscious self, a morbid state, the enjoyment of the luxury, and so on. We were speaking about enjoying suffering in some way. So this really is Page's position. We have exactly the same debate a few years later in Germany, when we have Hermann Oppenheim on one end, who says what happens to these poor workers is that they have, not only do they go through working accidents in industrial environments and suffer fright and also bodily damage, but they then also have to go to court, and this is terrible. So the law is really the cause for the prolonged suffering. We have opposing Oppenheim more or less the whole psychiatric community of his time, but leading the group is Strümpel, who developed this term of Begehrungsvorstellung or Rentenkampfneurose, meaning ideas of greed or greedy ideas, and Rentenkampfneurose is a neurosis in the fight for one's pension. Or Rentenneurosen, it's the neurosis.
I suffer from it.
You suffer from it. It has also a Hebrew name. It's called pensionitis or something like that. They like to use here. Okay. But what is important to see is that both sides think that this is an illness. They don't say they are just pretending, but they have lost control over themselves. The question is just what has caused them to lose control. Is it the fear that their just demands will not be recognized, or is it the greed that develops after the trauma? So it's additional emotions, additional ideas, additional desires that develop in an unhinged mind and therefore can become excessive. We have exactly the same debate in the First World War. I will not show you the many quotes that I could. One of the main issues here among the German psychiatrists, for instance, is that they say the patients are not traumatized by what they have suffered in the war, but they behave like traumatized people because of what they have suffered, but what they now know they may suffer again. So it's their fear of the future, it's not a result of the past. So it's actually they have changed their attitude to the future and become very selfish. They no longer want to sacrifice themselves for their nation. And of course the response of the German psychiatrists, of the Association of German Psychiatry at the time, was to come out with a declaration that they put all their work in the service of the nation, fighting this kind of selfishness among the soldiers. We were speaking about survivors, and William Nederland, a psychoanalyst who in the 60s coined the term survivor syndrome, spoke about the fact that what keeps survivors in their traumatization is not simply what they have experienced, but a feeling of guilt for having survived. So what makes it impossible for them to come out of the survivor position is that they feel guilt. In fact, you can see with him it's shame, guilt, lifelong burden of pain. It's the fact of being the sole survivor of an entirely family group exterminated by the Nazis weighs on them. So it's the fact of having survived for Nederland which keeps the trauma going. It's not the experience under the Nazis itself. I come to the last two parts. In 1980, the American Psychiatric Association developed the concept of PTSD. You can see here Chaim Shatan smiling at us, one of the major players in this development of the concept of PTSD, which was inaugurated in 1980. It was developed for American soldiers who had come back from Vietnam and not reintegrated. So it was from the very beginning developed as a term for a chronic disorder, although it distinguished between acute and chronic. But in fact, its idea behind it is to give a label for soldiers who had come back in the 70s and for whom there was no clear label. And what the term said was that something happened to them that was outside the range of usual human experience or would have evoked significant symptoms in almost everyone. So you have a clear dose-response model. Something terrible happened. It was so out of the range of the ordinary that we cannot expect them to get over it. And this model was clearly, did not involve any ethical emotions, any moral emotions on the side of the soldiers, because it was supposed to give them compensation and treatment. And you would not want to say these soldiers are ill because they are selfish or something like that. You want to say it's because what happened, and not even because they're excessively moral. It's because of what happened during army service, 5 years back, 10 years back. Because otherwise the VA, the Veteran Administration, would not accept them as patients. So in 1980, there was an attempt made to exclude the alternative model completely out of psychiatric discourse. And this worked quite well. And I'll jump over this to the last one. Until in the last few years, in the context of Iraq and Afghanistan, a new concept emerged into American psychiatrist discourse, the concept of moral injury, which is defined as the damage done to one's conscience or moral compass when that person perpetrates, witnesses, or fails to prevent acts that transgress their own moral and ethical values or codes of conduct. So suddenly we have a new mental injury. It's not called now post-traumatic stress. Stress is no longer present in the same way. The word trauma is no longer present in the same way. In fact, the distinction between acute and chronic has been abolished in the way I presented it to you, because now even the acute moral injury is one that is caused by something moral, by something excessively unbearable in its violation of the moral compass or moral conscience. So I think you have more than 20 years after PTSD, the kind of complement to the PTSD. And as PTSD tried to develop a dose-response model that went all the way through, you now have a moral injury model that goes all the way through. And if you look in the internet and in papers, you can now see lots of attempts to bring together PTSD and moral injury and say, okay, what do they have in common? Where do they separate? And so on. This is the current state of the debate. And you can see that PTSD really works on the element of reflex, fear, and so on, while moral injury works on regret, shame, and so on. So you have now the two separate in two different categories, but continuous attempts to bring the two together so there can be a debate between them. Thank you.
Thank you, José. Dr. Rakefet Zalashik will comment on José's paper. Rakefet is a researcher at the School of Social and Political Sciences at the University of Edinburgh. She is a historian of medicine and the author of many articles on trauma, migration, gender, and Holocaust survivors, and the author of 2 books. A book in Hebrew, I'll read its name in Hebrew, Az Nefesh, Olim Nafesh. עולים, מהגרים והממסד הפסיכיאטרי בישראל, ראה אור בקיבוץ המאוחד ב-2008. The second book is in German. I have its name here, but for obvious reasons, I reserve my German only to strictly closed and private sessions. So I skipped the name. Oh, José, please.
No, with you, a private session.
Okay, yeah, it's always welcome. And
Shall I read it
so
out?
You want to read
Das
it?
unselige Erbe, die Geschichte der Psychiatrie in Palästina und Israel.
Danke.
Bitte.
And that was published in 2012. And an additional co-edited volume, and again I'll read the name in Hebrew, בסימן טראומה, עיונים ישראליים בזהות, זיכרון וייצוג, which came out just like month by Bar-Ilan University Press and the Kibbutz HaMeuchad Publishing House. Rakefet,
Thank you, Manny. Thanks for inviting me to comment on José's text. I read the full text, so I'll comment on the full text. I'll be fast because I'm tired, and I'm sure you are tired as well. So, in his text, José addresses the question how scientific trauma discourse try to account for the transformation of an acute stress reaction or disorder into chronic PTSD. After showing that there is no etiological model which explains why PTSD occurs or the connection between an acute and chronic disorder, he argues that the explanations also involve the question of morality and immorality, which of course have implications for the therapy and compensation. José chose 7 case studies, he only showed 5, presented in chronological order and with World War II as a clear watershed. He shows that until World War II, whether it was individuals who were involved in railway accidents, German workers who were injured during war, or soldiers in World War I suffering from shell shock, the transition from an acute trauma, which is caused directly by an unpredicted specific event, to a prolonged chronic trauma was always explained by a moral component, be it anxiety about the future, loss of self-control, greed, or unconscious and illegitimate desires. José points to a change in the discourse of trauma after World War II, spurred by the creation of the concentration camp survivor syndrome when dealing with Holocaust survivors. Here, the chronic traumatization is explained by feeling of rage, shame, and guilt for surviving the inferno. José argues that in the case of Holocaust survivors, explanations of greed or selfishness for the prolonged trauma were left out. However, the most significant innovation took place in 1980 when PTSD was included in the DSM to define the chronic state of trauma among Vietnam veterans, and this in contrast to previous etiologies which focused on the immediate trauma from the traumatic event. Here the focus was on self-traumatized perpetrators who suffer from guilt. Motivated by political and ideological considerations, the American mental health practitioners were moving away from the amoral explanation of chronic disorder. Another shift took place in the last 2 decades with the American veterans from Afghanistan and Iraq. With the use of moral injury, contemporary trauma discourse has brought morality back as a crucial factor in the development of post-traumatic disorders. It explains the trauma by the violence the traumatized directs at others. Now, a few comments. My first general comment is that if we look at the history of mental diseases and their etiologies, we see that the majority of mental diseases had a moral component and were explained by a moral component. So the fact that historically chronic trauma has a moral component as well, I believe should be understood in this context. Second, José claims that even though, and this is something you didn't mention, but you did mention the big text, second, José claims that even though compensation payments were at stake in the case of Holocaust survivors, secondary gain clearly was taboo as a theme for the trauma experts in the context of the Holocaust. This is factually incorrect. There were discussions about Rentenneurose when dealing with Holocaust survivers. Just an example, in 1962, the psychiatrist Levinger published an article in Der Nervenarzt titled Psychiatrische Untersuchungen in Israel. Okay, I'll say it, it's ridiculous. You want psychiatric examinations in Israel among with 800 cases with health claims because of Nazi persecution. And there where he conveys an accusation of his colleagues regarding simulations among survivors. And he says that even those who claimed compensations due to Rentenneurose were not cheating, but rather suffered from real neurosis and therefore are eligible to compensations. Now, third, José, you showed very well the amoral component in the case of rape victims, which you also left out, and the role of shame. I would like to add that this shame is not only subjective and individualistic, but also objective and collective, namely rape, sexual abuse, and the incest are also causing shame and social disgrace in the whole society, exactly because what you said about social spaces in the big text, understanding that such collective damage exists, like in the case of prostitution, which many mentioned might assist as a society to fight this phenomena. Now, analyzing chronic trauma through the moral component invites also the question of stigma and labeling. In this context, it is interesting to follow the discussion, the attempt to change combat PTSD to PTSI, post-traumatic stress injury. This in order to adjust it to injury instead of disorder. this in order to adjust it to the military language, to reduce stigma, and to encourage soldiers to seek help. Now, although in the DSM-5, PTSD was removed from the classification of anxiety disorder, and now it is classified in a new category, trauma and stressor-related disorders, it is still classified as a disorder. So we now have the term moral injury, which was mentioned, which is from the beginning classified as an injury and not as a disorder. This also leads me to the issue of acknowledgement and the gap between the existence of the medical term, on the one hand, whether it's moral injury or PTSD, and the lack of social acknowledgement, on the other hand, which causes more pain and suffering. Social acknowledgement in the case of rape victims and soldiers might contribute to the process of healing. And I guess that some of us are familiar with the discussions regarding awarding or not awarding the Purple Heart Award to American veterans who suffer from PTSD. I think that's it.
Thank you. We'll now take some comments from the floor. Please, Liora.
I wanted to return you to Anne-Marie, that you analyzed as post-traumatic. And I wanted to ask Anne-Marie, what would follow from this in your reading of his moral argument? Because he says, the minute they put this label on me, they won't hear me. And what is interesting here is that he tried to separate the moral claim from the trauma or whatever, the syndrome. But now when we see that the morality is entering into this post-trauma, what does it do to our distinction between moral claims and analysis of symptoms of disease? Can it be separated? The second question is about your 7 or whatever cases that you have, and it seemed to me, maybe I don't get it right, that it seems that there is the same phenomenon, and we keep on having different framework to explain it. But maybe they are different. And maybe there are that it's different. The rape and the war and the work place. Maybe they cause different feelings or they cause different injuries, and hence the different. So, how does this enter your? Because you generalize it into moral and immoral, and then we lose the ability to contextualize the different things that are happening, and maybe it's because it's different things.
Thank you. Yeah, thank you. First of all, Rakefet, thank you for the order you put into my examples. Yes, of course, in the written text I had a bit more than I presented here. I agree that the diagnosis, I think the moment you look at Améry as a patient rather than as a philosopher or as a thinker, and then everything he says becomes a symptom. I mean, then it's no longer, you no longer have to lead a dialogue with him. Then you can diagnose him, and the diagnosis is not a dialogue. So yes, I think for a mental health practitioner, his presentations, the way he presents his condition would be the presentation of chronic post-traumatic stress disorder. He really gives more or less all the symptoms.
He needs to be accused for his excess of morality, because this is what is causing
Not
his,
accused.
trauma.
No. The advantage of the psychiatrist or the psychoanalyst, then, I mean, I think once you accept this frame of reference, which I just present here, then you also have to accept the other side, which is that it's not judgmental. He's not accused of anything. He's being diagnosed.
But you saw that it's always with morality, so you are accused.
No.
self-pity.
No. When a psychoanalyst says or writes of somebody with a narcissistic personality disorder, he's not accusing this person. He is diagnosing this person. I think when you are speaking or writing as a social commentator, a philosopher, or whatever, you may be accusing. I think there is a problem. There are a lot of problems with mental health discourse in turning everything into pathology and working with this framework. But I think you can criticize that. But I think it does have at least a very distinct intention of not being judgmental, of not saying that if somebody, for instance, take the survivor syndrome. Of course, the survivors were not accused of feeling guilty. It was their guilt is taken as something that one would have to work with in therapy in order to alleviate it, not as something that they can be accused of. So with Améry, it would be the same thing. But I think resentment and his insistence on something impossible having to remain would be seen as a problem for him to go on living. And I think in a way his biography would justify to anybody from the therapeutic field that maybe if he could have given up on this, he might have continued living. So I think this is the way therapists look at things, not in a judgmental way, but in trying to look at the handle from where they can work as therapists. Where would they have to intervene? Where could they lead? Then, after having a diagnosis, where could they then conduct some kind of dialogue? But it would be a therapeutic dialogue. It would never be an equal dialogue. I mean, it would never be a philosophical dialogue. It would never be a dialogue where you have to take seriously what he says in terms of social structures or changes or anything like that. It would always be a dialogue whose aim is to understand what his problem is and how his problem can be alleviated. So this is a very different dialogue. It would still be a dialogue, but the diagnostic and the therapeutic one. I mean, first a diagnostic and then a therapeutic one that deals with symptoms. So I think from the therapeutic stance, there is no equality, there is no dialogue in the way you are looking for it. And he would not be heard in the way he would want to be heard, clearly not. Everything would be reinterpreted as a sign of a certain type of disorder. The second question that you raised was that I refer to these traumatic disorders or post-traumatic disorders as one entity that gets reinterpreted in different circumstances, and that maybe this is not how one should look at it. I agree with you that one could look at it differently, and there I simply follow the existing psychiatric or medical discourse that starts to use the term traumatic neurosis in the 1880s and then continuously uses the same post-traumatic or traumatic neurosis, the same terminology through these 150 years or so. Yes, perhaps one could adopt a different point of view and say perhaps what they were suffering of was not post-traumatic disorders. I don't make this move. I stay within the discourse, and this has its limitations. I agree.
But even within this discourse, they are distinguished. For example, military PTSD is usually called combat PTSD, etc. So even within the medical discourse. Yeah, okay.
No, of course, somebody who suffers of survivor syndrome and a soldier who suffers of combat stress response are not the same. Even within medical discourse, this would not be the same phenomenon. I agree. But both of them, once it becomes chronic, suffer of a chronic post-traumatic disorder. The origin is different, and the moral element, once you don't simply go by the dose-response model, will be different. But don't you think that both in the end suffer of a post-traumatic disorder if you are looking at it from a psychiatric point of view?
Yes, but I'm saying that even within the psychiatric discourse, it's being distinguished, even with naming. So,
Yeah.
Yes, please.
Hi. Thank you for the talk. In fact, I read the paper with excitement. In fact, I wholeheartedly cheer the opening up of the trauma model to what might problematically be called morality, but at least adding another dimension in to interpret it. But my critique of that model is that it's being offered to us only as itself. It's being offered to us as only, this is medicine, and I'm operating purely within medicine, but nothing in medicine can purely be medicine. So for example, just to pick up on the previous point, how would it work in the clinic to say, well, you're suffering post-traumatic stress injury because of immorality, or because of amorality, or whatever the word might be. As soon as that word enters in and is said aloud to a patient, if that's the theoretical model, then I think it's fair to say that word has to be in the room. I think that would be troublesome for people, and then we have to try to explain it to them. But no, and then you're already in the hole. So I think that there's a face validity that's troublesome with the model. I'd also say that just as the most facile possible criticism, one that could get trotted out all the time for whatever medical diagnosis we might be making, in this model, race, class, gender, sexuality, no, but medicine, yes. All that other stuff, evacuated. So we're going to approach trauma solely from the perspective of, anyway. I guess I have a question, though, as opposed to just a point. With this teasing out, which I really welcome, I really think this is complicating things, and maybe the words aren't right, or maybe they are, I don't know. But I like it. I think there has to be more happening than the way we previously thought of things in order for it to be so persistent, enduring, and difficult, and intractable in some cases, But with these distinctions, with the different categories, the different theory behind what this is and what that is, the traditional taxonomical drive of medicine to categorize in psychiatry, is there a difference? So there's a distinction, but is there a meaningful difference when it comes to, for example, therapy? So we've created different ways to call this stuff. When it actually comes down to treating it, do you do meaningfully different things and get meaningfully different results? Is there a different approach now for these separate things, or are we just calling them different things for the sake of the category?
Yeah, I'm not sure I entirely understood your question, but if what you are asking is the following, then there is a difference in therapy. I think that whenever, what Rakefet just mentioned, from a psychoanalytic point of view, if you would speak from secondary gain, meaning that you develop symptoms in order to advance your social position, or get money, or get acknowledgement, or get consideration, or whatever. Or whether your symptoms develop out of greed, even though it's maybe not be purposefully developed greed, but you somehow have lost control over your greed. Or if what happens is that you give in to what Page called this morbid stage. Whenever these emotions come up that I put under the very, very general and simple label of immoral, part of the therapy is not to give in to the patient, to present the patient's demands as helpful to him or to her if you don't give in, both to society and to the patient, by not giving pension, by not providing the acknowledgement, by not providing a special status, and so on. This is presented not only as being good social policy, because you don't want to pay pensions to people who don't deserve them, it's also presented as therapeutic at the same time. While whenever the feelings that are mentioned are the ones that I put under the very general heading of moral, guilt, shame, part of the response that is advocated as being therapeutic, as Rakefet mentioned before, is providing acknowledgement, providing recognition, giving voice, providing compensation, and so on and so forth. So yes, I think I would divide, the two positions according to the therapeutic recommendations that I think go along with the two titles that I imposed, but that I think are kind of intuitive. That if you speak of somebody acting out of selfishness, then perhaps the best response is not to allow the patient to take over. Not only for us who don't want to be taken over, but also for the patient who has to learn his limits or her boundaries. I mean, this is the nice thing about the therapeutic discourse. It's always to help the person whom you impose the boundaries on. It's never for yourself or for the rest. Is that in the direction of what you asked? I'm not sure I properly understood your question.
I think that's
okay.
Fair. I guess push back a little bit by saying, who are we to judge who is acting primarily in secondary gain? I think that distinction is oftentimes trickier than need be, and oftentimes I guess medicine wants to say, okay, I'm going to take this big thing and now I'm going to break it up into many smaller things. It's this, it's this, it's this, it's this. We'll approach it in all these different ways. And although I welcome the complicating gesture, and I think it's useful, sometimes I wonder if all these things are co-occurring. So the person who has secondary gain also has all these other real things happening too. It's a very complex disorder.
No, I agree.
Yes, please.
Can I?
I don't know if you're aware of this additional diagnosis. The post-traumatic stress disorder, as it stands, it was created to describe the reactions to acute things that happen, like somebody was raped or somebody participated in a combat or there was a natural disaster. But a new diagnosis that has not yet been included in the DSM, but it's been widely used by psychiatrists and some psychologists, is called the complex post-traumatic stress disorder, which more effectively captures so not the chronic, but the complex, which more effectively captures what happened with the victims of the Holocaust or victims of prolonged captivity. Oh, good, yeah. Very good.
Have time for everything, so yeah, you missed in my talk the complex PTSD. Rakefet referred to, yeah.
Okay, yeah. So these more so I had questions whether you had any insights about if there's any degree. So this more effectively captures what happens with the victims of the Holocaust or prisoners of war, or in the case, for example, in my country, in Colombia, victims of prolonged captivity who have been kidnapped for years and 10 years later released, and the changes, the psychological changes that they experience are very different from what happens with a victim of one combat or one natural disaster, because they're like structural changes in how their mind and attachments work. And so I was wondering if you had any insights into if the injuries into the moral realm are different in quantity or quality, or how does it work in the case of complex PTSD?
Yeah. Maybe I should just make one thing very clear. I have no insight into trauma at all. I only try to provide insight into what psychiatrists write. So I don't know anything about trauma. I only know about the texts I read. Now, the point that I try to make here in my in the written paper that I didn't refer here to in terms of complex PTSD, is that the Ptsd model introduced something very clearly quantitative on the one hand, but also something that did not ultimately distinguish between acute and chronic otherwise than in temporality. If it lasts 1 month, 3 months, 6 months, you give it each time different names, but you don't actually distinguish in any other way other than for how long it lasts, and there is no way to explain why certain people develop chronic post-traumatic disorders and others don't. There's simply no clear model of explanation. People can develop delayed post-traumatic disorder, 20 years after something happened. Others develop acute, others develop both acute and chronic, others develop only chronic without having the acute before, and there simply is no model that can explain all these things. So all this is in the 1980s. What happened is that in response to this, there was a kind of competition of victims that developed, because PTSD was developed for soldiers, mainly, to give them the label that they can get treatment and pension for. And because this was also the period of in which, certainly in the United States, the feminist movement asserted itself, the competition of victims that developed was where do we find most of the traumatized people? Among the men, the soldiers, or among the women who are victims of male violence? And this kind of seminal book by Judith Herman, Trauma and Recovery, very clearly states most of the victims are women, while PTSD refers to the paradigmatic victim as a man. And so they want to change that perspective, the gender perspective, on one hand. On the other hand, though, they want to introduce an additional element of what you refer to as this kind of deeper going change that happens not in war, but in domestic violence. And I think for me what was interesting, and again this points to the point that I only try to analyze this discourse, is that in Judy Louis Herman's book, you can find both the Droz response model, because she tries to plug into the PTSD discourse. So she doesn't say this is something different, but you can see that she says there's a simple direct relationship between the severity of the trauma and its impact. So this is the Droz response. There was something happened, and this defines the impact. And then you see that she goes on to another question, which is what happens then to these victims, that they become, and again, this is not judgmental. I want to make that very clear. Certainly, Judy Louis Herman doesn't write judgmentally about rape victims or victims of domestic violence or sexual abuse. So preoccupation with shame, self-loathing, and the sense of failure is not in order to criticize them, but actually to bring in this additional development. So for me, her book is interesting in the way in which she uses both models alternatively in the same book, because one explains the severity of the complex trauma simply by the severity of the original violence, and she goes at great length to explain why domestic abuse is kind of the worst type of violence, and this brings us back to trust, because it's also this deep violation of trust, in contrast to war, where you expect violence. On the other hand, she goes on to develop, to explain the complexity of complex PTSD by these additional factors. So for me, this is a kind of more or less immediate, I mean, it's a decade, but a response to PTSD saying we don't, we from our side, in this term, the we would be, I think, the feminist position, we don't allow this removal of all the moral elements out of the discourse. We want to bring it back. And so this would be, in my historical presentation, it will be the pre-stage to the moral injury, which then brings the moral element back into the soldier's injury.
Sure.
Just, excuse me, just a quick comment, which I forgot to mention. The number one cause for PTSD being acknowledged in the American Army is sexual harassment of female soldiers by their peers, male peers.
But that's in conditions of peace, I guess.
No, during the war, when they are in Iraq and Afghanistan. Yes.
Shai.
You can, of course, argue whether how it's being diagnosed and improved. There is also politics of this, but these are the numbers.
José, thank you for, in some ways, bringing the conversation back a full circle, both to how we started yesterday, and also to actually even the name of the conference, the ethics of pain. So on some level, we're back to the question that we began with, as whether pain is just a sensation or is it also an interpretation. And I think that this is the difference between the two theories that you're presenting, except that the interpretation of pain that you've shown us is a very specific interpretation. It's a moral interpretation. And so one question is, what would be the difference between just a simple social construction or subjective construction or social construction of the trauma and this more specific moral construction of the trauma? And this ties to the other subtitle of the conference, Religious and Secular Suffering. So I think that there's an old tradition of thinking about the soul as a moral entity. That is, the soul is not just a psychological entity, but really the soul is about morality and therapeutics. In a way, ethics is a therapy for the soul, and it brings it back to its normal stage. In a way, modern therapy is following this model, at least to an extent, in trying to heal not just the physical aspect, but and the psychic aspects, but also the moral aspects of the soul. But in an interesting way, the way you present it is without moralizing, which is very different from the religious discussion. And so we see a kind of secularization of this problem. Put it differently, that what religion, at least certain religions, tell us is that pain has to do with sin. That is, with an opening of a gap between oneself and God and one and oneself, and that here pain is a kind of also a distance from morality, but in a very secularized context. So it's a suggestion more than a question.
Yes, no, I accept your suggestion. I think it very much fits what I want to say in that sense that, in the written paper where I wrote that it's a working draft, this is really true. I mean, this is something that I think I need to frame a bit better. So this is very helpful. Trauma, I think the concept of trauma, which developed a few decades after psychiatry became a more institutionalized force and took over the care of the soul in that sense from the priests, offered tried to offer a non-religious, really a secular interpretation of, for instance, in hysteria, of demon possession and things like that, by explaining all these events as symptoms of an illness rather than as a punishment for misdeeds. For possessed women are no longer women who obviously have done something wrong and are now being punished by these demons, but they are suffering of an illness. And I think you are absolutely right that there's this attempt of a non-moral discourse on a lot of phenomena that previously were dealt with morally by the church, or also, suffering because something happens to you is not a trial. It has no purpose. And if you're suffering from it, it will not purify you. There's no point in this suffering. So I agree with you. This is the attempt is to develop a therapeutic, non-moralizing stance towards morality. I agree, exactly. This is what I think, and this is why I think this debate is going on, because one tries to get it out even more, and the other sort of leaves it in, but tries then to have a therapeutic attitude to it. I completely agree.
Any more comments or questions? Okay, so I hope you will agree with me that this was a collective, shareable delight. And I want to thank our speakers and to thank all of you, and thank you all.
Anyways, I just want to thank all the participants, especially the participants who have joined us from abroad. I hope for some of you, this is your first visit to Israel, so we hope to see you again. And to those of you who are already feel here at home, obviously this is also the case. Thank you also to the chairs and the presenters of this panel. We have more activities. I guess if you're staying for more than a week, you're welcome to join us for next week's conference. It's a smaller conference that will be dealing with reproductive technologies and the family. And you're all on our mailing list, so you'll get invitations in due course. So thank you again, everyone.
Thank you.